Greeting everyone. My name is Salah Hassan, and I'm the director of the Africa Institute in Sharjah, United Arab Emirates. I'm also a professor of African and African diaspora art history and visual cultures at Cornell University in New York. This is the first in a series of webinars organized by the Africa Institute to discuss the effect of COVID-19 on Africa and the steps that African nations are taking to tackle the spread of the pandemic. Allow me to say a few words about the Africa Institute. The Africa Institute is a newly established postgraduate studies institute in Sharjah, UAE. It is, as I mentioned, a postgraduate studies, but it's also a research institution, and it's also a think tank. Its roots goes back to 1976, when there was a conference on Afro-Arab relations, and one of the recommendations of it at the time is to establish such an institute for the study of African and Arab relations. The institute is decreed recently by the government of Sharjah, and its mandate is actually African and African diaspora studies. Africa here is perceived globally, we are hosting this as part of our mission to educate people about Africa, to educate people about their cultures, their diaspora, and all aspects of the society. The PhD program and the master's program will be in humanities and the social sciences, and will also include interdisciplinary concentrations that will involve African-Arab relations, Black and African political and philosophical thought, Indian Ocean circulations, among many other things that are actually prompted by the locale itself, which is Sharjah, or the area of the Gulf, that incorporate all of these relations with Africa and Asia through the Indian Ocean. This first webinar is organized in collaboration with the Institute for Comparative Modernities at Cornell University in Ithaca, New York. Let me say it is with great pleasure that I welcome our two featured guest speakers. But before then, I would like also to welcome all registered participants who are joining us through our webinar link. I'm also happy to say that we have, yesterday, I didn't see how many registers now, but over 100 registered participants who are following this webinar live as we speak. So to all registrants, I must say that we are very grateful for their interest in the webinar. This is in and of itself a proof that the challenges that the African continent and its people are facing with COVID-19, among other crises, matters a great deal to many people across the globe. So thank you. There are two important notes before I begin the webinar and to welcome our guests. The first point is that from the beginning, and since we announced the webinar, we received several complaints and feedback that alerted us to the problem of access to the app itself of the webinar. The alternative is, of course, YouTube. So I wanted to alert people is that those who could not, or know people who could not join the webinar, that the webinar is currently being live streamed on our YouTube channel, which is also called the Africa Institute. So also registrants can copy the link in the top left corner of their screen and share it with their interested viewers. So I also wanted to note that the webinar will be recorded, and a version of it with Arabic subtitles will be hosted on the Africa Institute YouTube channel. That is basically to maximize access for the public worldwide. Our today's webinar will feature two leading health experts from the northeastern part of Africa. Both have been in the forefront of combating COVID-19 pandemic. So allow me on your behalf to welcome Dr. Dawit Wondimagegn, who is joining us from Addis Ababa, Ethiopia, and also welcome Dr. Muntaser El Tayeb Ibrahim, who's joining us from Khartoum, Sudan. Allow me to say just a few words about the background of our guests and their impressive accomplishment. Dr. Dawit is the Chief Executive Director of the College of Health and Sciences and Vice President of Addis Ababa University, and a specialist in the area of global mental health, family medicine, medical ethics, psychotherapy, knowledge and translation, and postpartum depression. Dr. Muntaser El Tayeb Ibrahim is the director of the Institute of Endemic Diseases, Faculty of Medicine, University of Khartoum in Sudan. He's a founding member of the African Society of Human Genetics and the Sudanese National Academy of Science. He is a molecular biologist by training and a geneticist as well. So in this panel, we hope to cover many issues, among them the measures that are in place to tackle the spread of the virus in African countries, how the population is responding to such measures, and the challenges that African nations are facing considering the expected spread of the virus vis-a-vis the current health infrastructure and the economic crisis that the many countries in the African continents are suffering from. So, and we will also check on what the appropriate action that African countries should or could undertake to confront such circumstances. Of course, we are open to discussions from our audience on the webinar across the globe who can send their questions on the chat section. And we will do our best, of course, to answer many of the questions. So let me begin this webinar by asking each of our two guests, Dr. Dawit and Dr. Muntaser, to say just a few words about their professional background in terms of areas of specialization, current research and practice, and overall experience, and how such background relate to the current COVID-19 crisis. So I should begin with you, Dr. Dawit. Welcome to the webinar. Go ahead. I think you are muted. Yeah, now you're okay.
Yes. Thank you, Dr. Hassan, for a very kind introduction. So my name is Dawit. I'm trained as a psychiatrist, but I have a background in public policy and health service development. I teach and work at Addis Ababa University, which is the largest university in Ethiopia, and one of the oldest. My current leadership role is as the Chief Executive Director of the College of Health Sciences, which also hosts the Tukur Anbassa Hospital, which is the largest tertiary referral hospital in Ethiopia. And with that comes my role in dealing with the COVID-19 pandemic. As a nation's tertiary, only tertiary level hospital, our role to deal with this epidemic is reserved for a time when and if a community-wide community transmission of the epidemic happens in Ethiopia. So currently we are preparing our hospital towards that. But at the same time, because we are also host to the College of Health Sciences, which is the nation's leading healthcare teaching and research institute, our institution leads all the consulting and advising of the national effort to deal with the pandemic. And that's where my involvement comes from. Thank you.
Great, thank you so much, Dr. Dawit. Dr. Muntaser, I don't know if you heard the question. It's just about to say a few more words about your background and how your training, your expertise, your experiences relates to the current pandemic.
Thank you, Salah. I heard you saying something about patients. So I don't work with patients directly. I'm a non-clinical scientist. And but as a geneticist, I have established years ago the unit of disease and diversity, which looks at the relationship of hosts and parasites, including viruses. Viruses are the ultimate parasites. I haven't done a lot of work on viruses, but as director of the institute, we have responded quite early to the pandemic and formed a COVID task force at the institute in collaboration with the Ministry of Health. And this group includes mathematicians, epidemiologists, clinicians, local biologists and the rest of the concerned specialties.
Thank you so much, Dr. Muntaser. I will begin with a general question, which is what measures you think are in place to tackle the spread of the virus in each of the two nations, and how the population are responding? Because we see in the news, there's of course, when you think in terms of the different population, whether it's in Ethiopia or Sudan, there are people who live comfortably and in places where social distancing is possible. There is also, from the other side, there are laborers and there are people who are making their living day by day. And they also lived in cramped situations in neighborhoods that are crowded. So there are two difficulties that are actually, they are suffering from. One is, of course, an economic, that they cannot make a good living, or at least just the basic living for them to survive. But at the same time, also, it's very difficult under those contexts to have social distancing. What will be your response to this, and what is the experience? We start with you, Dawit, in terms of Ethiopia, especially Addis Ababa.
Yeah, thank you, Salah. You know, Ethiopia is a very big country. It's 110, not as large as Sudan, but it's close. We have 110 million people, and most people live in the rural areas. And Addis Ababa is the capital, probably close to something like 6 million people live in Addis. And when the COVID-19 infection was confirmed for the first time on March 13th, 2020, the government of Ethiopia put in place some measures to combat the transmission of the infection. Immediately after the first infection, I think the government decided to close down schools, and then introduced some measures, which I will probably, it will be better to describe them as soft lockdowns. It almost feels like that we have to do this, but we cannot really impose it as much as it is imposed in other places for a number of reasons, which I will come back to. But in addition to that, the decision to quarantine every traveler that's coming to Ethiopia for 14 days, mandatory quarantining was imposed. As you know, Addis Ababa is a gateway to most African countries, and the number of people who travel through just one airport is huge, and that decision I think needed to be made. And then, of course, the other public health interventions like washing hands, wearing masks, and social distancing came one by one. But in general, people comply to some of the restrictions, and the recommendations, like washing hands seems to be working very well. People are quite compliant with that. As I just demonstrated, some of the mechanisms of preventing, like coughing and so on also seems to work fine. But when it comes to social distancing, you see, we're not a society that are used to living scattered lives. And most people live in one room houses, where the recommendation of 2 meters distance between individuals is more of a luxury, because most people basically live in 2 by 2 room houses. And in this circumstance, it's quite difficult to implement the social distancing. And secondly, in terms of lockdowns and staying at home, most people depend on daily subsistence. They have to go out every day and work. If they don't do that, then it's as simple as saying that they cannot eat. So the choice becomes staying at home and starving, and while preventing yourself from an unknown disease, which you may or you may not get, or even if you get, you may the chance are you'll be better, unless you have some really pre-existing conditions that makes you vulnerable. And I think people are intelligent and they make their own choices, and the choice is to survive. And most people come out and continue to work. In general, that's the situation I see. People want to comply, but they can't comply, and they need to have really quite clear directions towards that they're supposed to comply with. Thank you.
Thank you so much. Muntaser, the same for you in Sudan. How do you think people are really managing these challenges and how they are actually facing this epidemic? What measures that are taken and how people are responding?
In terms of awareness, I think this is one of the first mass pandemics that is taking the world, by the grip in the age of globalization, especially mass media. So people, I think, if you watch the TV, you are saturated about COVID-19. Every household. There is no household that doesn't have a TV, nor a mobile phone. So I think in terms of awareness, there is no single spot in the world, except for few, maybe nomadic groups who are not really aware of this pandemic. It's a phenomenon in itself, something that need to be looked at in the future. How people react globally, against such a threat. But so I won't go into the details of what people should do, and I think Minister of Health here have taken appropriate action early on. But I would just like to reiterate a point that my colleague have mentioned, which is I think Africa issues with Africa's problem here in the pandemic is more on the socio-economic part, because in terms of wealth, which divide the world now into parts, wealth is not really in the clinical, in the disease itself, intervention, the medical intervention. There ain't much to do. This is a virus that we know very little about. There is no vaccine, no treatment. You can follow the squabble, on different interventions in the developed world. But in the developed world, government can afford, some of the rich government can afford to subsidize this lockdown. We don't have this kind of economic luxury here because first, economy is, especially Sudan economy, is in shambles, as you know. It's not a state it's mostly an informal economy, and people are living from hand to mouth. So this is a huge challenge. If not for the revolution in Sudan, the situation could have been different, because people are now more law-abiding, than before. So if you talk about law-abidingness, this is where people differ between countries and culture. I think countries are more into staying at home and observing the instructions of the government. Things are better than others. It makes you wonder. A country like Brazil, the president itself is leading the skepticism, on the COVID-19. But what I want to mention lastly, that the main measure to combat this disease, which is social distancing, hoping that we could minimize the burden, on the health system, and have the herd immunity working in batches, not at the same time, as some people have been advocating. This social distancing is probably counterintuitive, as he said, in Africa. But this is the only thing now, because epidemics historically, if people read, these Homo sapiens and other books that talks about the history of epidemics, is about crowd. The more crowds you have, the more the chance to spread epidemics and pandemics. And that's the problem. That's what happened in Europe actually in the medieval age, because Europe was the most crowded and overpopulated country. Led to the disaster of the Black Death and others.
Yeah, thank you. But I wanted to emphasize one thing. I mean, that is one of the main reasons that I asked this question, is that the measures and how governments or nations like Sudan, Ethiopia, take to combat the disease, of course, will have its consequences in a sense of how these places are perceived. There is, of course, and I think that's a question to both of you. I don't think maybe Sudan kind of faced some endemic diseases or some epidemic to some degree. I think pandemic is a little bit of a bigger word, whether it's cholera, whether it's other disease. There's Ebola, of course. I don't think it is in Ethiopia and Sudan, but Uganda, and also in West Africa, Guinea, Sierra Leone, and those places. I think, is there any lessons to learn? Because there are success stories of combating these diseases in Ebola. Nigeria, for example, Senegal managed to keep it at its border. Mauritania, the same, even though it's bordering all of these major countries that were center of the Ebola. So my question to both of you, any reflections on this issue?
Yes, I think it all boils down to how resilient nations are to respond to such events like epidemics or any kind of disaster. Like, how flexible are we in terms of responding to that? And a first experience is always the most challenging one. And the case of Ebola is a good example, because when we had the recent Ebola in Africa, the recent Ebola epidemic, the experience was there already from the past Ebola experience, so other countries were better prepared for it. But I think in terms of our resilience, three factors always seem to be our Achilles to respond. One is our level of preparedness in terms of really having a clear policy and guidelines and procedures, clarifying the roles and responsibilities of all the actors that should be involved in epidemic control should be there. And in most places, these policies, either they're not there, and when they're there, they're not really communicated enough, so that every sector is not aware how to respond, because that creates a lot of confusion, and that lack of clarity makes it difficult for systems to respond. That's one. And the other is the level of, in terms of really health emergencies, you depend on your healthcare workers and the commitment and existing situation before the epidemic determines how your workforce is going to respond to this. And I am afraid that most countries in Africa, certainly including ours, have been quite negligent of attending to the needs of their healthcare workers. And with these two challenges, the response to epidemics becomes difficult. You add to that the lack of experience with this specific respiratory epidemic makes it a bit challenging. But the lesson is, what is the challenge with this? The challenge with this, because we don't have the experience, the readiness, and the direct policies, we may be forced to adopt what is being done elsewhere as interventions when this epidemic happens here. And I think with COVID is a very good example of that, because we've been hearing about COVID for like a couple of months, 3 months before it came to Africa. When it reached Africa, most countries, including ours, responded by adopting how other countries responded to it, instead of really considering what the impact of that response is. So these are some of the challenges in terms of really using your own experience, but at the same time being overwhelmed by the amount of information and the kind of infomania that we tend to react than reflect and decide on what course of actions to take. Thank you.
Yeah, actually, before Dr. Muntaser, you answer, I was just going to have a follow-up question that may help a great deal in terms of answering my question. First, I must say, we must salute from this platform Dr. Akram Adetom, because of his famous tweets that shows his seriousness, especially with the circumstances of Sudan, that he was really serious and frank and in his public appearances, which is definitely helpful. I mean, we rarely encounter ministers of that with that caliber. But this is a follow-up question. Yeah, Dr. Muntaser, you can take it on, but also you, Dr. Dawit, can also follow up, which is about the question that I ask is that there are experiences like Senegal and other places that have dealt with some epidemics, the Zika, Ebola. Nigeria had some success that it managed to curb the epidemic, and so of the Ebola. So is there any kind of platforms where Africans really sharing knowledge? Because this would have helped in answering this question. What is your take on this, Muntaser?
There is an African CDC, and there is platforms, but what are they doing? That's another question, because Africans actually, if you may say so, discovered each other probably no longer than three decades ago. Scientists started to collaborate and find common challenges and try to act. Because before that, if you want to go to Chad from Khartoum, you need to go to Paris and then take the plane and go to Chad. So thanks to Cuban Airways now, we can go to anywhere in Africa. So the links between Africans is still building up. The mentality, what I call it, mindset that allows them to act, in a collective way against these challenges. And these challenges are not going anywhere, by the way. So now we have 3 or 4 viral epidemics in the last couple of decades, which is quite, I wouldn't say abnormal, but quite frequent. Because if you look from the Spanish flu, it took time until we got the next pandemic. Now, with the travel across the world, the new behavioral traits in our species, we are going to be faced by more and more, situation like the current one. So we need to think at a nation, level, and also at the continental and regional state. We have to think of what to do. Ebola, for example, the epidemics that took part in Africa before, the situation was a bit different, because Ebola was, like a focal kind of outbreak. And then the world responded, the whole world responded. And by the way, Ebola started in Sudan, by the way, in southern Sudan in the 1970s. The epidemics cannot be compared to each other, because this one in particular is really quite an infectious virus, and the death toll in many countries is quite high. So we hope, it will not take its toll in Africa the way it is taking its toll in the north. But are we prepared? You can never be prepared for this kind of epidemics enough. I mean, you can never be prepared enough, because infectious agents will continue to cross the species barrier, will continue to surprise us on what they can inflict. Because if you look at this COVID-19, it's a completely new disease. Every day, people are discovering new information about it. So I think the best thing to do is not really to talk about the health systems, and I salute also Akram from here. He is the most unlucky minister, because when he came, he found immediately Rift Valley and then cholera, and then, he spent most of his ministerial duties, trying to combat outbreaks. But I don't think it's about the health system, because even the best health system in the world, couldn't face this epidemic, couldn't adequately, confront it. But what we need to do in Africa is to build the capacity to understand these diseases. I mean, in terms of science, now we are doing our own simulation of what would the epidemic look like in weeks and months. We can't just rely on the study by London School of Hygiene, which is based on a very fixed model, in projection what will happen. So Africa needs to come up with its own scientific capacity, to look into these matters.
Thank you so much. Dawit, do you want to add something to this? Yeah.
Yes, I think your question regarding whether there is a platform for African institutions and countries to actually get together and work out some of these challenges, my answer to that is, I think, a straightforward no. We have a long way to reach there, in my opinion, because to date, south to south kind of relationship, partnership between African institutes is really still a rarity, and the kind of partnership with the northern institutions is the norm and the predominant form of partnership and collaboration. Because African nations, when it comes to research and science and the development of both, requires that African academic institutions collaborate between each other and work towards a common goal. There are, of course, attempts in the past few years, like with the establishment of, for example, the African Alliance for African Universities for Research. Some certain universities try to work together in terms of promoting research between themselves, but still these are just the beginnings. Dr. Muntaser was also mentioning the African CDC. It's a new idea modeled on a particular framework. So we'll see how that's going to work. But in terms of really having a platform for us as Africans to get together and talk about this, it's really we're not there. So that's one thing we need to improve.
Yeah, when one surveys the news, I mean, like in just preparation for this, platform or panel, I tried just to look at the news in the last few days, New York Times, the major magazines, WHO report, and so forth. So the scenarios about Africa seems to move between two, poles. One is a doomsday scenario, which is what you read in the WHO report, which I take seriously. That is 190,000 will die, and that 83,000 to 190 may die from this, and that 29 million to 44 million could be infected in the first year of the pandemic. If the containment, of course, they had a qualifier, fails. So this is in terms of the doomsday. There's a lot of, really pessimistic scenarios. On the other side, there are some good news. There are reports about, for example, the Senegal Institute Pasteur, which mentioned the fact that they managed to devise a testing kit for the equivalent of, it's accessible to anybody, and that they're testing everyone who want to be tested, or actually they're testing the whole population. So that is one way of combating, and that they are actually using 3D printers to actually manufacture, respirators. So these are some of the good news, but there's something that is not understandable, and that came in some of the questions that we just received from the audience, is that, and that's also in the New York Times 2 days ago, that the pattern seemed to be slower, that the disease spread so fast in populated countries in Europe, in the so-called first world, and so forth, so the North, and the East too. But in Africa, it seems to be slower. And so there are many things that in the article that was speculating, and I wonder your take on this, which is, one is that the average population, for example, they said Sudan is about 60-something% of the population are under 25. Could this be a reason that is, or there is really a study? Is it just a lack of testing that we don't know about the rest? Or there is something that, but there's also, I wanted to have your take also on this misconception in the early days that, I mean, there's the myth of that Ebola doesn't touch Black people. And then the other thing is also that Ebola cannot, sorry, not Ebola, the coronavirus cannot, infect Black people, or it cannot, the hot climate, it cannot survive in the hot climate. But then that can be disputed also, that there are places that has a hot climate and yet it's spreading in it. So I wanted your take on this, and between these two scenarios, and also this puzzle about the slow, spread of the virus itself.
We tried to look at that because these are really important questions. Because the doomsday scenario was a source of really panic and anxiety for many people, I'm sure in the whole of Africa, certainly in Ethiopia. And while we saw the progress of the illness in Ethiopia, after 8 weeks, we were around 200 cases, and all the modeling and the prediction that was being proposed in the early days was not really, was just went out of the window. So we tried to look at, colleagues in my institution, we tried to look at what explains this slow progress in Ethiopia. And we looked at 4 factors. And are there really testing related issues? Is it because really we don't test people that we're seeing lower number of cases? And we looked at both data in terms of really testing, what kind of test you're doing and who's you're testing. And the evidence we came up with showed us that even though the actual number of tests is not as high as in other places, but the number of negative tests for each positive, which is also another indicator of testing, was within an acceptable range. So we were testing enough individuals to get a positive result while a certain number was negative. That's too technical, but the message for us was the testing alone cannot really explain the situation, one. And the second is we look at change in morbidity and mortality. Even if we're not testing, this is a disease, if it manifests, you catch it because it overwhelms health systems. So we have not witnessed an increase in the number of people who are visiting the hospitals, or an increase in deaths and in some of the mortality funeral site surveys that our colleagues did. So the testing is not picking up. The assumptions that there are so many cases, but the testing is not picking up. We cannot really backed by evidence. And then we looked at some of the issues you mentioned, that are we immune somehow from this, or do we have a low susceptibility? And the evidence for that is not, again, conclusive. There are evidences which suggest that the prevalence of other infectious diseases, the high prevalence of malaria, TB, and so on, may have provided us with some kind of general immunity, not specific immunity. There are papers talking about altitude, temperature, and demography, which are all indicative but not conclusive. And then we also looked at the early intervention with the public health measures of quarantining people, isolating and contact tracing and so on, and some of the hand washing and other interventions. They definitely may have contributed towards the control of the spread. For example, a significant number of the patients who tested positive in Ethiopia were patients who were in quarantine. If the mandatory quarantining was not in place, then these individuals may have gone into the community, and that might have speed up the progress of the illness. So we have to be guided by the evidence, and our analysis so far to date indicates that there is some secondary data suggesting that this might take a slower trend, but not necessarily a less severe pattern. So we don't know. We're going to have a long wait, but we have not really escaped this by any stretch of the imagination.
Thank you so much. Dr. Muntaser, I remember in preparation for this in our earlier conversation, you've said something about the kind of research you do yourself, because I think the question I ask, beg for research. And you've talked about the area of diversity and endemic diseases. Could you just, continuing the commenting on the same question, just give us some idea about what are the directions of research that you could, at least provide some clarity?
Yes, I think that Dewitt have mentioned a lot of very valid points. So I'll just go immediately to answering your question. And also something that you mentioned yourself about Africa's population being mostly young. Africa is the youngest continent, as you know. And if you compare the outbreak to a fire, which is, this is a literal word that says, fire breaks, there is an outbreak of a disease. Fire needs dry grass, dry, vegetation to spread. So if you have, a kind of a landscape which is half green, half yellow and dry, the rate of fire, spreading in that in this environment is less than if you have a completely dry, material, for the fire to spread. So you can compare the green here with the age group. So this is one important reason that even in Europe and elsewhere, the age group was detrimental in the clinical symptoms showing up. They have more resistance. So as David said, the disease is about clinical symptoms. You know it by people coming to the hospital, by death. So these are two important things. These features vary between one population to another. Even in the current outbreak, you can see, that the outbreak is not homogeneous. There is no homogeneity in its spread. And you can't say it will reach Africa after months. This is not justified because the travel between Ethiopia and China is busiest globally. So Ethiopia should have been one early spot. And Dawit, I'm touching wood now. I don't want to turn your luck. I would love for Africa to have its luck continuing, but Ethiopia should have been one of the earliest in terms of travel. But this actually is one important evidence for epidemiologists to look at, is the human factor is the most important factor, because this is the material, just like the dry grass, the straw, whatever, where the fire spread, it spreads among humans. So if humans have difference in their genetic susceptibility to a disease, this will reflect differently. We have modeled here in this country the effect of a temperature globally, and the association, is not quite strong. What came strong actually is the genetic predisposition. You can even see it in Europe, in neighboring countries where people have different genetic markers. We identify, clearly a genetic predisposition profile for people who are more likely to encounter COVID-19, and then go to the most severe phenotype, which is death.
Of course, when you touch on genetics, you touch on a bomb or on something that is a minefield.
Let me remind you. You said blacks, and said Africans will not get it. So people said African Americans are getting it by the score. In fact, if you look at African Americans and all Americas, the genetic profile of race is not the indicator. If you look at ethnic groups, those ethnic groups are quite diverse, and they look in many instances to Europeans more than to Africans because of history. So if you look at the genetic profile of African Americans in New York, they are as predisposed regarding these markers as the Caucasians, or it's not the word, as the European whites. So the appearance, in terms of ethnicity, is quite misleading. If you look at the color.
No, but I mean, of course, you're answering my question about the myth, but the question, of course, this at least attract our attention to the economics. Because one thing that this virus did is expose the inequalities. That is globally north-south, and at the same time, it also exposed inequalities within the West itself. So the hardest hit statistically in the United States is among minorities like African American, Latinos, and others, despite the fact that they constitute less than 20% of the, even within one city. If you notice, there was a very good article in the Times Magazine that surveyed the whole neighborhood. So you find the hardest hit. So the economic status also played, and then also there's something else that and I wonder what you thought of that also. Another aspect of inequality, or also another aspect, that it exposed the lack of readiness in the West, and that the health system itself is not working well because of neoliberal policies, because of the models of outsourcing. So in those countries, they didn't have enough actually, masks or gloves or respirators, and it took time for many places. Of course, the lack of public health system or universal health system in the US, that's what this, the lack of readiness for a pandemic like this has exposed, is that this is when you really have to have a robust health system that's accessible to all, and that you have to have the readiness. So I don't know what your take on this in terms of the inequality access.
Look, let me start first by your first point, because whenever you mention ethnicity and disease and populations, people becomes wary and sensitive, and this is a backdrop from the Second World War, the Holocaust and other things. But we need to face this, that we are not equal, in getting diseases. You said Ebola does not affect everyone on Earth because of the climate, so it affects us here in Africa. So inequality here in Sudan, for example, if you look at the disease, it's affecting the upper class because they travel more. So it is not the disease of the poor like in New York. because the poor in New York has to go out and not to confine themselves, and they have to find a living, and that's one of the major risk factors. So that's why they got more of this disease, but not because they are more susceptible. Also, you see it in the clinical doctors in the UK, and that was also a case of inequality, because most of those who died were from the minorities, because they had to stay in the front line. But I'm talking about something you can see it not only in Africa, you can see it in South America also, in the places where the Indo-Europeans did not expand. You can see it in South Asia. You know, the disease in Vietnam, in many parts of the world, it is not as you would have expected. We have to face the fact that we don't encounter diseases equally because of our history. You know, it's a whole field. It's called genetic history, and this is what I work on actually.
Okay. So any comment, Dawit, on this issue?
Yes, I think it's really I don't think the COVID-19 pandemic is telling us anything new, so to say, in terms of health disparities in global health. It's just exposed what used to be a global knowledge, but happening in real time in local communities. So it all boils down to our attitude towards what health is. And there is this dichotomy about our attitude toward health. If you ask me, I think health is an absolute human rights issue. And there are nations and many people who think like that. But there is also a significant and powerful forces in the world which take health as a commodity. As long as this dichotomy of health as an absolute human right and as a commodity persists in the world, we are going to see more and more impacts of illness affecting the most vulnerable in society, and the inequality in health will continue. So the discussion that we need to take up is maybe the world needs to learn is like, for example, the issue of torture. More or less torture, all nations of the world agree that it is a human rights issue. Health is probably one of the most underrated means of oppression and causes of human rights abuse in the world, and it has to really rise up into a platform where it is taken as an absolute human rights, and then everybody should get it. Unless we reach there, for us, for example, the disparity is not really news. We've been living with malaria, TB, HIV, all sorts of other illnesses which disproportionately affect the poor and the vulnerable of the world. With that knowledge, COVID is just exposing the whole scenario for the entire world. It is an opportunity for the world to learn that we cannot really continue to take health as a commodity. Look at one of the best responses throughout the nation, even for COVID. Those who have a very good public health system seem to fare better, irrespective of their national economic standing. So absolute human rights is a way forward, and it has to be one of the anchoring paradigms we have to come out of this when we move forward.
You know, I'm going to take some of the questions that came actually from the audience. One of them is actually intriguing because, as you know, in the case of Italy, some neighboring countries didn't come to the rescue, and they kind of became more nationalist in terms of the spread of their resources, or at least stretching them, or the generosity towards their neighbors. So the question is that it says Cuba is a country with complex reality and economic distress. And if you recall, it's the Cuban doctors that arrive in Italy to help, while big neighbors like France, Germany, didn't do that. And so and it's a country in economic distress, but however, the epidemic is very much under control. Is there a conversation or exchange with Cuba in order to know what Cubans are really doing? Because they did actually intervene in Africa many times when there were cases. So I think Ethiopia have dealt with Cuban before in different, so if you can have a perspective on the Cuban, what is it that the Cuban are doing that other people are not doing?
Yeah, I think I will have to look for the, go back to and check the data, but I will give you what my take is on this. Cuba, you see, has one of the best health systems in the world because it recognized health as a basic necessity to be provided by the state for each and every individual. So they have a very robust and strong health system, clear guidelines, clear policies, because going back a little bit, COVID-19 happened in a pre-existing world where countries have different kinds of health systems, some geared towards economics, some towards rights and so on. And that is, I think, what is determining how countries are faring. In fact, one of my hypotheses is that if African countries make it through this with as much as possible, as little as possible harm, one of the reasons would be probably, again, even if it is poor in terms of infrastructure, that most health systems are public, helps in terms of access, in terms of really defining responsibility of care on the state. And this will take most health systems far. So I think the Cuba case is a very good example of historically, they've never really, it's very rarely that you would hear Cuba struggling with a public health problem, because they have a very strong public health system, and it boils down to that. And they recognize health as a basic necessity to be provided by the state for its citizens.
Yeah, Muntaser, you have any take on this question, or?
Yeah, no, after the Michael Moore's movie, nobody has anything to add about Cuba.
Okay. So let me just then, and I think that question is, to both of you, but I think Dawit is right into your corner, is what kind of psychological impact such diseases can have on the population, and what kind of measures, people can take in that domain, because people talk about the economy, access to health, but there is the other issue of the mental health issue.
Yeah, I think all pandemics bring our existential fears to the front, because as you know, we all live under the kind of universal denial that death is far away, and we'll reach it at the very end of our lives, and we pretty much do well with that assumption. But when pandemics like this come and start to kill people, it brings to the fore that death is imminent, and all our fear and anxiety comes out. And most people would struggle with fear of their own body, that because we're being told, and we're educating people that if you wash your hands, if you don't touch your face, then you'll be fine. Then that means your body is something you want to protect, but at the same time you want to protect yourself from. So it's a very difficult position that brings people in psychologically. And then fear of the other, like with the social distancing and the knowledge that we're getting this from somebody else, want us to avoid the people we love, but at the same time we also want to protect them. So it puts individuals in this double-bind situation. And this double-bind situation creates a lot of anxiety, panic, and all sorts of mental health problems. But majority of people will do well. only significant number of people will suffer from long-term psychological problems if they already had past pre-existing mental health conditions. Otherwise, all of us will go through a stage of distress about this, but most would actually go through it. And what is the source of this psychological distress? Information. COVID-19 as much.
Want to add to this, or sorry, go ahead.
COVID-19 is as much an epidemic of information as it is a viral epidemic, because we are getting bombarded by endless information, and it renders people helpless, and that's the most significant psychological effect that comes out of it. So these factors really make it psychologically very hard, putting us in a double bind, but being bombarded by endless information. So what people could do to prevent themselves from this is to limit access to information and choose one source of information, stick to it. Don't overdose yourself with a lot of information for which there is no evidence anyway. So that really helps. And keeping a particular routine also said to help with this. But I'm not going to give psychotherapy on YouTube.
Okay, so
I think we have to be prepared for a new kind of behavior, which is also it's a challenge, you know. Dr. Dewitt talked about yes, an individual the psychological status and challenges, and also the part of the community issues. But I think we need to counsel also, as he mentioned, we need to counsel the community, and also people need to know the future. You know, one big issue now is what is going to happen to us when we open up. What is going to is this disease going to continue? What is the socioeconomic? What are the socioeconomic challenges? Are there going to be enough food, for example, in many countries where people are forced to stay at home? So we need really to address these issues in a holistic way, and it's a duty of the psychiatrist, psychologist, and social scientist to think of the well-being, the health, well-being of the human being, you know, following this trauma, because essentially this is a trauma, you know. It's something that happened without being prepared, you know, and it is affecting all aspects of our life, from household to the economy.
Definitely, because I mean, one of the things that I've read is the impact. I mean, of course, in many of the African nations, there is the supermarket, and that is only available to the people who are able to have access to, who have the money to spend. And that, but the food, what do they, not the chain, I'm talking about the access and also flow itself for the population, because most of the poor depend on these small markets, especially in villages, farmers and so forth. And if this situation continue, I think there is a fear of hunger. There is a fear because the food, source or sources, or the chain of sources are actually would be affected or affected by this. And I think you also, we've had questions about the impact on the workforce, education, and workforce policy. I think both of you have answered it in one way or another. But there was one question which actually has been a question at the beginning, especially the model of public health to combat the disease. There was of course, the testing, the aggressive, social distancing measures, and all of those things, and washing hand, hygiene, all of those things. But there was also something that, especially the UK, has decided to follow first and then abandon, with the Prime Minister himself getting infected by the disease, which is the herd immunity. And that's a question that came from one of the people in the audience. What is your take on this? I mean, there's a lot of criticism that's available in the media, but I would love to at least satisfy this.
Yeah, this is also another double-bind situation for global health leaders, I think. Dr. Muntaser will be in a better position to answer this, but my take on it is that so far we really don't have evidence that people who recover from the COVID-19 infection necessarily develop immunity, and the risk and chance of reinfection is said to be high. And my only evidence, a very good evidence, which looked at the trajectory of, kind of try to model the trajectory of this virus. What we've learned that there is going to be a seasonal pattern, and it will take probably years, up to 5 years, before it reaches to a level where there is some sort of herd immunity. So how would this fare in Africa? I think in terms of our response in Africa, we have to be very sensitive to the challenge that the interventions present to the public, and focusing on interventions that would protect the most vulnerable should take precedence over large-scale population-level kind of interventions, which are not going to be sustainable. And interventions with such public health measures should also focus on urban areas, because there is a lot of overcrowding in urban areas. The fact that the majority of our population lives in rural areas gives us an opportunity to actually design an intervention to protect rural communities and their livelihoods to continue, so that the fear of starvation and hunger could be minimized, and also look into our own cultural ways of dealing with epidemics in the past. So there are very good practices, for example, from Ethiopia, in rural Ethiopia, in past epidemics on social proper, humane social distancing, which protects people, but also cares for the person sick, are available. And we will be served well if we focus on such interventions. And the rest of the population has to work. Not working is not even an option. And what that would mean is exposing a significant number of our population for infection if it is there. But at the same time, the chance of recovery from this illness, if you don't have a pre-existing condition, is very high. So with that, we can hope for some kind of herd immunity to come earlier than probably 5 years. But I don't think that as a strategy is something one should indulge in without due consideration for its impact.
Dr. Muntaser, I mean, as a scientist working on diversity measurements and statistics, yeah. I think you probably have more to add.
Right. So you mentioned Boris Johnson and the herd immunity. And this is not the first time, actually, that disease become part of this evolutionary thinking game, if you might call it. Britain, Sweden, and Germany, were early on in this business. It's always come from the right-wing circles, and fortunately, it is difficult to adopt in these days, because essentially the herd immunity is that the disease will take off and then take on, and who dies, and who survives, and this is natural selection. It's a natural selection. It's the best. It's the better for everybody. And some people even now think within this mental framework. Of course, because they will be, protected and in their ivory towers and away from the epidemic, just like the epidemics of the Middle Age. Unfortunately, this epidemic affects everybody. It doesn't. I mean, class-wise. Class-wise, it's a disease that can affect the prime minister, the ministers. Even in Iran, the first, hard-hit country, it was especially among the political elite. And but what is herd immunity itself? There is no one single herd immunity because diseases cross-protect. For example, people were thinking that in the 1819 flu have left a legacy of immunity among the population of the world. That's why we didn't have another pandemic after that. So that brings me back to the question of variation and diversity. If you have a population of pretty homogeneous genetic structure, which means that their immune system looks alike also, because they share experience, the chance of this epidemic killing more people is higher than when you have an epidemic affecting people as diverse as the African continent population. Because, for example, if you like to enter even the host cell, you use this ACE2 receptor. This receptor differs. And we saw this story in the HIV in Europe, because Europeans were more protected to HIV than Africans, because they had this deletion in one of the HIV receptors in the macrophage and other cells, CD4s and others, which is called the CCR32, CCR deletion 32. So, but what are you going to allow a disease killing number you don't know, so that as to have this herd immunity? I think this is completely unethical. What we should do is do these measures that we have now. We will understand, for example, in each country, for example, in countries where you are expecting more to die when you lift the lockdown, you have to take extra care. Again, this country where there is evidence that there is a herd immunity developing in batches. I mentioned this word earlier, in batches, so that when you make a lockdown, it's not a complete lockdown. We called it a soft lockdown earlier, Dawit. So the transmission is continuing, then you can see the impact, the clinical impact of the disease. So that's my take on that.
A question related to what you, Dr. Dawit, said in terms of limiting information, which is, I feel it, that is, we're really bombarded with so many, news about the pandemic, contradictory sometimes, and also distressing to watch. That's why they said the subscription to Netflix, increased multifold. So people, I guess, trying to avoid the distress of the isolation first, but also the bad news. But there was a question about, okay, if we have to limit our resources, what do you recommend, both of you, as the best source to remain informed? Is it the WHO, or is there any trusted sources that you think one from time to time can glimpse on them? So that's a question for both of you. David?
Yeah. Yes. I think the trust is a very, if we're going to come out of this with as little harm as possible, the trust we have on our leaders and on institutions that run health, global health, is quite determining. So as a public health professional myself, I look for information, global information. I go for the WHO recommendations because irrespective of whatever controversies people talk about this, as a citizen, as an individual, what is important to me? What is important to me is I know enough about this virus to protect myself and my loved ones against it. That's it. For this kind of information, global institutions are way trustworthy than others. So I would start from there. And then I would trust the information that is provided by the state's health authorities, because there is no profit in this, irrespective of the level of trust between government and the public in our pre-existing situations. No one is going to profit from this. So I will have no reason to doubt reports and information. So for me, I will go to the WHO website. I will go to the Ethiopian Ministry of Health website and their information, and the Ethiopian Public Health Institute. That would be a kind of information for like, in terms of preventing and understanding what I need to do as an individual. But in terms of news, then it's a choice. I can pick one local media outlet with credibility, because institutions just don't go bad during pandemics. Every institution has a history of credibility. Go after that, but limit the amount of time you get from those. So I will go for a local station with credibility, which was proven in the past. And then I will go for my global information, probably 2 or 3 outlets with opposing perspectives on things, so that I will get the information, but balancing it and using it is still left to me. That would be the approach I would take.
Muntaser?
Yes, I will go also for common sense, of course, which is a major thing that guides us as humans now. And I totally agree that we need leadership in times of crisis. We need more leadership more than ever, and I think it's good we have an African now on top of the WHO, which is leading this. But I would love to have this opportunity to introduce some change of mindset, because the history of not WHO, of the UN, United Nations, is is adopting I think pre-1990s way of thinking. That things are universal. There are universal measures. There is things that fits everywhere. And you can see it now in some of the WHO guidelines. Some of the WHO guidelines are not well informed. And don't want to be critical also in this time. Because it's a time of unity. But I think in the future, I would love that the director, who is African, will use his his mandate and his term to introduce fundamental reforms in this organization. Not because Mr. Trump wanted so. It's completely against Mr. Trump, justification. But we need it in Africa. There is the history. In history, there was an African who was a great leader of one of the WHO sections, which is TDR. He was a Nigerian, and he was one of the best leader, of that organization. So, so that's my comment. I wish that this opportunity can be taken to change some of the mindset.
Yeah. There's a question that actually I try to avoid because it has been repeated many times, but I thought I'll ask you anyway, because it came from different side. I had it, I delayed it, but let us take it on, which is the issue of testing vaccine in Africa, and especially after the controversy of the French doctors who later apologized because of the backlash about how Africa would be the best testing grounds. I mean, Can you take this on, Dawit?
Yeah, thank you. I think but personally, I'm more surprised by how we reacted to it, to those suggestions than that people actually said them, because we know this because there is media, and the political correctness is the kind of the state of the world. But we have to go back and look at the research platform and paradigm in Africa. And it is characterized by dependence. Because to do good primary research in Africa, you have to have resources, and that's where we are limited. And we go and look for these resources elsewhere, and we usually find them in the north and in other places. And that helps to get the resources, but reinforces the dominant power relationship that has always existed between the north and the south. And this is the reality of research as we know it. So people know, for doing research that wouldn't go easily in other places because of the human rights issues, they will get away with it in Africa, and they proposed it. So the power dynamic is one, but we also have to question how are we making it possible? How African scholars and leaders like myself are permitting this to be a possibility? Because the lack of investment in building the capacity for research in Africa by Africans for Africa is non-existent. Most African nations, including mine, don't spend, I would not even say enough, but any meaningful amount to understand local health problems and then figure out solutions. That leaves the platform open for exploitation. So that's what's making it possible. And two, in terms of building scholarship and original thinkers from Africa, the kind of research which is characterized by power relationship, as I said, has helped to create good technical researchers in Africa, but really very few, if any, who take it on the next level. And that's why probably I'm really quite keen on the Senegal story you Salah was mentioning there. Like, what kind of researchers led that? How did they really manage to come up with such a brilliant innovation in a very low period of that? That's where we take a lesson, so that we build the capacity of African researchers in-house, so that these questions can be answered by Africans. As long as these gaps remain, people will come out and say, let's go to Africa and collect our data, and we'll still be talking about it. But the right investment has to be there. The dependent relationship has to be modified to be a true partnership. And I think those are probably my points.
Muntaser? Yeah.
Yes, I agree with that. And I'd like to say that we are no longer in 1960s. So it's in the interest of the world and scientists in the developed world that you have a capacity present in Africa. Because if you would like to do any research, you can't really, if you don't have a presence in the ground. A parachute, as they call it, parachute research and science, is going to be perpetually misleading. You will come for months or something and try to understand a complex phenomenon yourself, and it will fail. And that's what happened again and again, in Africa. So it's in the interest of the world that this way, that is perspective of doing science in Africa, in the nostalgic attitude, you know, that you see in movies like Indiana Jones and Angelina Jolie and others, that you know you come and help. I think people will find it difficult and counterintuitive. You know, I'm saying this not in a resentful way, but in a constructive way. You know, we'd like, you know, to understand, for example, the consequences of the COVID here in Africa, not just as a vaccine, not a vaccine that will benefit, you know, the communities in the north or the west, but what happened here in Africa. Maybe if you understand the local mechanisms of resistance, if at all there is resistance, you might help you develop better intervention in the future. So we need true partnership, which is not even now, as people talk a lot about it, is still a lip service.
That's really great. I mean, we're about to get to the end of this, and this has been really a brilliant presentation by both of you, and we're really grateful. Even the comment that comes from audience that are not sometimes questioned, they just really thanking you guys for being in the trenches, for being in the forefront, and so forth. So one of the questions that are nagging, and I've seen it for me actually, but also for everyone, is to think about the post-pandemic. I mean, this, shall be over soon. I mean, I think one day it will leave us. Maybe there will be other pandemics, but this will also shall pass in a way. But of course, one of the issues we discussed is the exposure of the inequality globally, and also the importance of healthcare, as you said, access to it as an important human right, basic human right. But there's something else that when we think about it is the issue of the environment and the climate, and how we as humans have not been keen or kind to the environment and to nature. So, and especially when you think, it was one of the actually interesting themes of a triennial of architecture here recently, that is organized by the Sharjah Foundation and the Triennial of Architecture here in Sharjah, is the theme of the rights of future generations, which is something to think about in the context of the continent itself, within the environment. I mean, your comments on this, because I think that is one thing that this pandemic, with the total lockdown the whole world, I mean, people have seen, there are comments about how water in many places become cleaner, cities also has less pollution, dolphins, I don't know if it's a myth or reality, dolphins are now in the canals of Venice in Italy, having a good time. Turtles, sea turtles and others that are actually totally absent. The quality even of the air and the water becomes. So your take in terms of vis-a-vis the African continent, because that's the future, the rights of future generation. The climate and the environment is something that is really to think about. I just wonder in this kind of, to conclude this, both of you, if you can comment on this. Just thinking ahead, post the pandemic.
Yeah, I think one of the questions this pandemic has asked us and is still asking us, in my opinion, is that what is our responsibility to each other? That is a question we're being asked, both in terms of really how we deal with the pandemic itself, but in terms of really reminding us that we need each other to survive, and that includes the environment. And those are really very good examples. It makes you smile, like dolphins showing up in the canals of Venice is really a good thing that we hear. But I think it has served the world that what we have been doing to each other and to the environment. And if there is a lesson that we can take forward for Africa, is that we need each other, but in the absence of a place that we live in, that's not going to amount to anything. So we have to learn from this particular history that there is something we can do about this. And COVID has very specific things to remind us, because the entire risk of infection is on our hands, both figuratively and literally. So it is on our hands to prevent ourselves from this illness, but also it empowers us to know that as individual human beings, we have impact. But in terms of how we go beyond this post-COVID, I will mention that first, I think I would like to mention one practical thing we have to remember in terms of really people who are engaged with the health system. Because we have a poor health system, the epidemic we should fear the most is the epidemic of the diseases that we know. Because of COVID, most patients are not coming to the health, to hospitals. They're staying at home. And if we don't find a way to bring them to hospitals or to attend to them while they are at home, we are going to see more deaths and suffering from non-COVID conditions than from COVID. So that's really one thing, one practical thing we have to remember. If we are going to survive this, we have to pay attention to that. But in terms of really more idealistic things, as I said, my hope out of this for Africa is for nations to take health as an absolute human right, as I said before, and work towards achieving that to their citizens. And two, in terms of promoting research within Africa to solve problems of Africa, to find a way to release African researchers and thinkers from the dependence that is put on all of us because of the failure of investment of nations to fund research in Africa. These are the two things probably we should take. And next time we run into a larger public health issue, we'll have researchers and data coming up from Africa saying, this is our issue, this is how we see it, and this is how we are going to solve it. Unless we do those two things, then we'll be in the same circle of responding to pandemics and then talking about this. Thank you so much.
Dr. Muntaser, the last word for you.
I won't add much to what Dewitt said, but upon reflection, it's quite interesting that a few megabases of nucleic acid will send such a sobering message to our species. I think this is in itself, we need to again reflect on what is the relationship between humans and the ecosystem, as you have mentioned. And secondly, it brought quite acutely the fact that the economy is not about these bubbles. Now in this country, people are thinking of what are we going to eat? So in case this situation comes again, and hopefully this epidemic is going to, most epidemics are transient, by nature, but in case it happens again and we have to be locked down, we need to think of the necessities of life, not the way the global economy now is investing on, because it needs to grow on and on, So I think these are two important things that Africa need to think and put some emphasis on agriculture, the environment, and green economy and other things. Yeah.
But it's also the right of the future generation. I mean, we owe them, to leave them a better world, and we owe them, something better than this, not to.
Yeah, we're not. We don't. This is how I see it. We don't live only in an inherited world, but a borrowed one too. We've borrowed this world from our children, so we owe it to them that we protect it.
One last thing also that I think you mentioned, Dawit, and I think in Sudan, Dr. Muntaser, you will agree with me, is the stigma around the disease. Because in the first cases, there was incident, I'm not sure if it is corroborated or not, that certain families deny that the relative who passed away are actually passed away from coronavirus, and denying that. This actually reminds me of the earlier debate on AIDS, also, and the stigma towards it, which is now, of course, it's you know, AIDS patients are surviving. There are the, you know, medicine, or this medicine that can prolong their lives, and so it's no longer as it used to be stigmatized. But that's another issue with diseases, is that they tend to be stigmatized, and that, I think, is also something you pointed to that we must you know, think about. But we will have to end. We reached the end of it. In fact, we passed, and this is because of your generosity with time, your experience, the brilliant point that you point. And I think I really cannot even find the word to thank you both for the time. I know it's a busy time. I know you are in the forefront finding the disease. So thank you for allowing this time to at least engage with us in this debate, which I really, from all the comment that I can see on the screen coming from the participant subscribers to this registrants, they are all really impressed with what you have said. They find it very informative. So thank you so much. One last thing that I say before we leave is that this will be the first of series. We are hoping to cover North Africa, West Africa, Southern Africa, and to continue even with diaspora and other issues where one could focus, or wherever Africans are. But of course, our concern is also the larger humanity, because we can't live in isolation. We share the world with others. Diseases can start in Africa and travel somewhere else. It's interesting to see how sometimes the stigmatizing of China, but then people forget, for example, the Spanish flu, it started in the United States. It just has the Spanish name. So countries are not immune. And with more globalization, as you said, Dr. Muntaser earlier, that people travel. You cannot stop it. Ebola reached the United States through health workers, through travelers, and so forth. So thank you so much for providing this information. And for those registrants, we promise you that we'll continue this series and we'll advertise them more. So thanks to everyone. And thank you so much again, Dr. Dawit, Dr. Muntaser, and for everyone who contributed. I also must thank the staff of the Africa Institute. This is the first time, and my first time, to experiment with this. We were very worried about the failure. We were afraid of, and thank God that the telephone works. The cell phone works for you, Dr. Muntaser. We were very worried about the disruption of services. Many people to thank: Sat'an, Sharif, Sarah, Hajar, Reem, and everybody who's in the staff. Salma, these are people, I must thank them because they are the people who are behind the scene working on this. Sharif also, our tech person, Vijay, they all work very hard to make this possible. We learn a lot. I think we will do it better next time. Thank you so much.
Thank you. Thank you so much.
Bye.